Welcome, everyone. My name is Yvette Gaughan. I'm a registered dietitian in medical affairs with Nestle Health Science, and I am delighted to have the opportunity to introduce our speakers today and assist with the Q&A session. Our presentation today is Nutrition in the Surgery Trauma ICU. Why and how? I am very pleased to present today's speakers, Dr. Philip Prest and Jessica Justice Reith. Dr. Prest attended the Philadelphia College of Osteopathic Medicine, where he became a doctor and completed his general surgery residency. He then went on to Emory University and Grady Memorial Hospital to do a fellowship in trauma and critical care. Dr. Prest has practiced trauma, surgical critical care, and emergency general surgery with the Prisma Health USC Medical Group at Richland Memorial Hospital. This hospital is a level 1 trauma center in Columbia, South Carolina, and he's been there since 2015. Dr. Prest has delivered several presentations. In fact, he had the honor of speaking at the American College of Surgeons fall meeting. And Dr. Prest is author and co-author to various abstracts and publications. And he and our second speaker today, Jessica Justice Reith, have recently published some outstanding work doing this together on surgical trauma patients that they will be sharing with us today. Our second speaker, Jessica Justice Reith, is a surgical nutrition support dietitian for the USC Medical Group at Palmetto Health in Columbia, South Carolina. She earned her bachelor's at Clemson University and completed her internship at the Mayo Clinic in Jacksonville, Florida. Prior to Jessica's current position with the trauma surgeons at USC Medical Group, Jessica was a nutrition support and trauma relief dietitian at Palmetto Richland, which is now Prisma Health. Over the past 6 years, Jessica has pursued her research interest in critically ill patients and has been very busy implementing a volume-based protocol and gathering data in the surgical trauma intensive care unit. So with that, I give a very warm welcome to our speakers, Dr. Prest and Jessica. I'll turn it over to you, Dr. Prest.
Well, thank you so much for that kind introduction and for this wonderful opportunity. We are both very excited and very humbled to be with you and to share with you our experiences. So with that, let's get started. Here are your objectives. We're going to discuss the importance of early enteral nutrition, different aspects of different formulations, and some recent evidence from our institution substantiating all of this. A quick word about our institution and just where we come from. We are an approximately 650-bed hospital in Columbia, South Carolina. We're a verified level 1 trauma center, and we are the major teaching institution for the University of South Carolina School of Medicine's Columbia campus. For such a small state, South Carolina currently has 5 level 1 trauma centers, as well as a smattering of level 2 and level 3 trauma centers. You can see there's a concentration in the upstate or the northwest part of the state, as well as along the coastline. For those of you who know, Columbia is smack dab in the center of the state, and with patients being referred to us really from all different directions, very much on a busy night, it feels like the crosshairs of the state are focused very solely on my pager and on our team. So we're a very busy place. Our trauma patients suffer a myriad of injuries, but as you can see from this graph, we have a significant percentage of penetrating trauma injuries. We're running about 15 or sometimes 16% per year, and that's about twice the national average of violent crimes. And we're very busy. We've been growing steadily over recent years, and as the population around here expands, I suspect we'll continue to grow our services. Within our facility, we have a beautiful new surgical trauma ICU. It's got all the bells and all the whistles. It really is a wonderful and beautiful place to work. Specifically, it has 18 beds and admits about 600 patients per year. And these are the patients who have formed the basis of our research projects. I think it's important to further set the stage with regards to our patient population. In stark contrast to other ICUs that typically combat a singular pathology superimposed on numerous chronic conditions, our patients often have several new organ systems that are all injured simultaneously. Brain, spine, ribs, bones, pulmonary injuries, open abdomen, belly trauma, holes in all sorts of places, and on and on and on. And this results in a significantly increased catabolic state of our patients. This drives up fluid or blood requirements, and the associated inflammation leads to capillary leak, which serves to exacerbate and potentiate this process. Much of what we spend our time doing is this: fighting the lethal triad, or the lethal triad of death, if you want to be dramatic about it. But acidosis, hypothermia, and hypercoagulability serve to be very present and very critically significant in our patients. If we can break this triad and end this cycle, we will do very well for our patients. And here's how it works. Patients in our trauma center come in after a substantial injury and with active hemorrhage. The ongoing blood loss leads to hypothermia as well as a condition of metabolic acidosis. The acidosis and the hypothermia in combination form to potentiate coagulopathy. And in the presence of active hemorrhage, the coagulopathy will simply repeat the entire cycle. This was coined the bloody vicious cycle by Dr. Moore several years ago, and it's as critical to our patients' survival and our understanding of trauma pathophysiology today as it was back then. Another important thing we do is fight infection in the surgical trauma ICU, but we need to remember that our patients don't arrive infected. Other parts of our hospital admit patients for infection every single day. They admit for urosepsis, for pneumonia, for diverticulosis, whatever, but we don't do that. We admit for injury, and then we work really, really hard to prevent the development of a superimposed infection. Things like central lines, Foley catheters, infected hardware, or hardware through awful wounds, contaminated wounds. These are things that can lead to infections that our patients develop after being here for some amount of time. And this is reflected in graphs like this, which illustrate when trauma patients die. I should remind you all that I'm a simple-minded trauma surgeon, and expressions like when trauma patients die are expressions that often get my attention and the attention of our team. And something like this is super helpful. So you can see that most of our patients who are going to pass away immediately, within the first 10 to 20 minutes after an actual injury. This is usually from an airway type problem. Someone's in a really bad car accident, they fracture C1 or C2, they can't breathe, and they pass away before help arrives. Or sometimes this happens with profound exsanguination. A bad gunshot wound to the heart results in a devastating injury and fatal exsanguination. So most of those patients pass away. The good news is that if you get to the trauma center, you're going to do pretty darn well up until about the 2-hour peak, or time rather, when there's another spike in when patients pass away. So why do these patients die? This is often from ongoing bleeding or from increasing neurologic demise. So maybe you have a bad injury and we're able to at least partially control or temporize the blood loss, but then eventually we just can't win and the patient passes away. Or maybe there's an increasing closed head injury that ends up in the patient passing away also. If we can get you through the first 2 or 3 hours, odds are pretty good that you're going to make it. But you can notice another spike that happens about the 4-week point. That is when patients get infected. These are patients whose stay in the ICU has necessitated prolonged device use, whether it's a central line, a PICC line, ventilators, whatever the case may be. These are patients who end up getting infected about a month after they've been here. And that ongoing sepsis is what leads to their death. So from a nutrition perspective now, how can we help this unique patient population? In order to answer that, we needed to clarify our very own history. And as you can see, the findings are not that inspiring. Looking back historically at our data from 2011, we can see that we were on average initiating enteral feeds around day 4. We were reaching our 80% goal on day 9, or very often never in our patient population, and less than half of our patients ever met their caloric or their protein needs. We had no formal enteral nutrition protocols. We were using whole protein formulations. And of note, we did not have a singular dedicated dietitian in our surgical trauma ICU. There was a team of individuals helping to take care of our patients, but that led to inconsistency and changes in plans. And yet, we should have known better. The 2009 critical care guidelines were already out and were well established at this time, and they supported early enteral nutrition, and specifically with an emphasis on both volume and calories. So we knew where we needed to get to, but we didn't know how to safely get there. So let's figure this out. We really need to answer 3 questions: when to feed, what to feed, and how much, and how to safely and effectively accomplish this. So when to feed. This is a good opportunity to have our first poll question. And what we really want to ask everyone is for some feedback on when at your institution you're starting enteral nutrition in your surgical or trauma patients. So let's take a second. You can all answer the polls, and we'll use that moving forward. Responses are coming in.
All right, it looks like we've got some good responses here to the poll. It looks like we have 42% are feeding within 24 hours, 46% in 48 hours, and 72 hours we have 11%, and then just 1% that are waiting more than 72 hours.
Terrific. Well, that means that you all are doing a pretty good job, certainly better than we were, and certainly within the current guidelines. The 2016 guidelines, which have obviously since come out, suggest the use of early enteral nutrition within 24 to 48 hours. So it looks like almost all of you are achieving that. And of note, it also put a significant emphasis on protein more than simply raw calories. I can't stress this enough, and I think in many ways we're spoiled here, but it should go without saying that obviously we can't feed enterally without enteral access. So any patient who's intubated, anyone with an altered mental status, either from trauma or intoxication or baseline, whatever the case may be, these patients need an NG or an OG tube. They need it immediately. So for those of you who are feeding within 24 hours, obviously you're not having a problem with this. But I can't tell you how many individuals tell us that at their institutions, this is sometimes a problem. I certainly appreciate that it's not always easy, but it should go without saying that it is absolutely necessary. The benefits of early enteral nutrition may be intuitive to most of us in this audience, but it's important to realize that there is excellent data to support its use as well. McClave et al. Performed a meta-analysis of 21 randomized controlled trials, over half of which were looking at infection, and they found significant risk reduction with regards to infectious morbidity as well as overall mortality. When you look at this and try to decide why that might be the case, the theory is that this helps maintain gut integrity, which modulates the stress response and is independent of disease severity. Now, this sounds amazingly perfect, in fact, maybe even fine-tuned for someone like us who is trying to fight the lethal triad of death. In terms now of what to feed, I'm going to hand the program over to Jessica, who's going to go into details about our program.
Thanks, Dr. Press. So we talked about when to feed. The next question is, what do we feed our patients? So to kind of help orient us a little bit, let's briefly define surgical immunonutrition versus standard nutrition. Standard nutrition is most often seen, especially in treatment of malnutrition. The focus is more on our calories and protein, and studies referenced really show a benefit in the surgical population only when used for 2 to 4 weeks minimum. Surgical immunonutrition has a much more acute intervention applied in the days before and after major elective surgeries. You see benefits from ingredients designed to meet distinct nutritional requirements caused by trauma or surgery. Recovery improves due to that combination of the ingredients that help modulate the immune, vascular, and inflammatory responses. So we know that 2016 guidelines included evidence where benefits were seen in specific populations, as you can see charted out here, specifically in our peri and post-op patients, severe trauma, and TBI patients. Here's a meta-analysis used as evidence in the guidelines to summarize the large trials using immunonutrition in major elective surgeries. John Drover and Darren Hyland analyzed 35 random control trials that included level 1 studies, showing about a 41% reduction in infection complications and a 2.38 reduction in hospital length of stay days. This is considered one of the largest and led to many more sub-analyses. Sub-analyses on infection included about 28 studies. They showed a clear benefit in GI surgery and in non-GI surgery. Immunonutrition is effective independent of anastomonic site studied, and it has shown a benefit in the lower or upper GI tract, or potentially both. Arginine is not as beneficial by itself, however. The studies showed it was the combination of arginine, fish oil, and nucleotides. When used by themselves, they didn't see the reduction in infection and length of stay, only when they found that those ingredients were combined together. So let's break it down. The mechanism of how depleted arginine causes an increased risk of infection and wound breakdown is twofold. There's a decrease in availability of arginine caused by your NDSCs, which activated by surgery. Once arginine is depleted, T cell dysfunction occurs, increasing the risk of infection, and decreased production of nitric oxide also occurs, decreasing tissue oxygenation and increasing wound breakdown. Over the next few slides, we'll show how giving immunonutrition, all the substrates together, help immunosuppression and make arginine more available to assist in wound. Remember, arginine is not the whole story. Omega-3 fatty acids, which are the most important components of EPA and DHA, as seen in fish oil, minimize the inflammatory response and improve T lymphocyte function. We think fish oil is important for arginine metabolism, especially in surgery patients. This study was very enlightening because we discovered that in 2014, when it was published, it can make the case that majority of your patients preparing for surgery are already deficient in omega-3s. 89% of those that were screened were found to be deficient per the OS scores. So they're already coming in a deficient state, going through surgery or trauma, and then further deplete them, which makes the argument for immunonutrition even more important. So the role of nucleotides. Dietary nucleotides are important non-protein nitrogenous compounds that serve as building blocks for RNA and DNA. These are essential in supporting the immune function. So majority of the body's systemic immune function is driven by the gut and gut-associated lymphoid tissue cell turnover that it can occur rapidly. These two entities overlap in immune health, and nucleotides are needed for both. So now that we've kind of broken down the nutrients, the important question is, are we going to see our patients, especially in the surgery and trauma population that have a high rate of GI intolerance, tolerate this combination of ingredients? And we know that tolerance greatly matters. There's not much comparing your different peptide-based immunonutrition formulas and tolerance, but this abstract is from Clinical Nutrition Week in 2014 done by the University of Tennessee. Formula A is 79% peptides and 50% MCT oil, and Formula B is 54% peptides and 20% MCT. Consecutively 3-month retrospective review found that there was no difference in those tests that you see below, such as C. diff, number of antibiotics, laxatives, or antimotility agents received. However, there was a difference in the days of diarrhea. Formula A with higher peptides and MCT had 3 times less diarrhea than Formula B with lower peptide and MCT. They believe that the higher amount of MCT impacted the diarrhea events. And as we all know as clinicians in the ICU, diarrhea can cause electrolyte imbalances, it can cause mobility issues, and can lead to a further length of stay within your intensive care unit. So, how do we safely feed this challenging population? When screening your ICU patients, most of our trauma patients are going to come in well nourished. However, they will have a significant increased risk for malnutrition due to their injury and inflammatory state. We know, based on all of our evidence in the past, these are the patients that benefit the most from an aggressive nutrition. Our most important macronutrient in this population is protein. Based on the studies done by Dr. Hyland et al., the goal is to meet 80% of the protein prescription for best outcome. So that is our aim within our own ICU, is our patients meeting at least 80% of the protein that we have prescribed to them on a daily basis. We also know calories are still important so that the protein is utilized correctly. We aim to also meet 80% of the caloric needs that we prescribe. And we use the Aspen 2016 guidelines to estimate, along with indirect calorimetry, which is the gold standard. This is going to fluctuate throughout the patient's ICU stay, so this is recalculated as frequently as we can to ensure that our patients are meeting the appropriate calorie and protein demand. So we not only have challenges with estimating nutrient needs, but also with ensuring that we're adequately delivering. The nature of these injuries mean frequent procedures leading to interruptions in nutrient delivery throughout the day. We need multiple surgeries requiring NPO depending on what your hospital's anesthesia practice is. We all know what the ortho add-on diet is. We're gonna, make them NPO tonight because we're gonna go for surgery tomorrow. Wait, we're gonna cancel the surgery. Don't make them NPO, so they're on and off. Open abdomens and abdominal pathologies can also make it difficult to feed these patients. So step 1 was reviewing the nutrition bundle that came out with the critical care guidelines. And we needed to look at 2 specific areas that would hopefully help improve nutrient delivery and provide some kind of how-to so that we had less interruptions for our patients. So first was determining a formalized protocol that would address these challenges. We also needed to define gastric intolerance, specifically gastric residual volumes. I am sure that all of us have had that nurse that has pulled back 20 mLs residual, or if you are a nurse listening, you've had a patient with a 20 ml residual, and you ask the physician, what should we do? You might get kind of a broad answer. The feeds end up getting held until the next morning on round. So it could be up to 12, 16 hours before these patients are fed again. And it's simply because we haven't defined exactly what is the intolerance and what should we do if there is intolerance, so that the nurse can kind of drive the nutrient delivery and hopefully get the patients restarted sooner. So the volume-based feeding protocol that appeased us the most was the PEP-UP one designed by Dr. Hyland. So we looked into all the different protocols that were being designed, and we found that this one would work best on our unit. So it starts with a specific type of formula to promote GI tolerance, since you are going to be working with higher rates and getting to goal rate quicker, which leads into number 2. You start the rates at 25 mLs an hour on day 1, and instead of increasing by small amounts like 10 every 4 hours or 10 every 6, which can sometimes take several days, you increase straight to goal target volume. Then we also added promotility agents to be started sooner, and we raised our gastric residual volume threshold and provided kind of a how-to to our nursing staff. Make note that the initial work only included 4 trauma patients and did not utilize peptide-based immunonutrition. So we were taking the evidence from the paper and then going to be applying it to a surgery trauma population. One will always look at the results of the studies before you start one, and when we took a look at this one, we found that 60.1% of its patients met their prescribed energy needs, and they met them earlier compared to the control. So this is how we kind of decided on PEP-UP to start in our own ICU. Here you can see our traditional methods. We had delayed start times, varying formulas, delayed and varying delivery rates, really no how-to for when our nursing staff experience an intolerance. Basically, we're kind of told that we'll cut it off and we'll talk about it later. With PEP-UP, we have our start time after resuscitation. We have a specific immunonutrition semi-elemental formula. We have a plan for proper increasing feeds. And we have a defined how-to for our nursing staff and what to do if there is an intolerance situation. So this is an example of the orders we use in our ICU. Also make note that this includes an automatic consult to the RD. So there is an option under the continuous for our physicians or nursing staff to click on that so that the patient is increased to some sort of volume until the RD can come in and make an assessment and prescribe a new total volume. And again, we have those do not check gastric residual orders that we went to in 2016, which we'll talk about in a second. But again, this provides the nurse with a how-to when intolerance is present. So in 2016, we decided that we were going to change to a do not check unless there was a sign of intolerance, such as nausea, distension, or the patient complaining of abdominal pain, because we were still finding a high number of inappropriate holds for our enteral feeds that were delaying delivery. So as you can see here, we do not check unless they have had an event such as distension or nausea. We look at if it's less than 500, we are going to continue tube feeds and continue to monitor. If the patient is greater than 500, we have the nurses cut the rate down to 25 an hour for 4 hours, recheck a residual amount. If it is continuing to just trend up, then we will cut the feeds off and ask the physicians to have a KUB ordered and investigate a little further. If it's less than 500, we kind of equate that to delayed gastric emptying and continue to monitor the patient. If there is an emesis episode, the feeds are immediately cut off and held for 4 hours. We'll restart at 25 and monitor the tolerance, recheck a residual amount, and ensure that it's not greater than 500. So we started our volume-based feeding or PEP-UP program in August of 2013 and included about 6 months of education. It does require strong nursing leadership and strong physician leadership. And as a dietitian that was here when we started it, you do have to be present to kind of, again, work with nursing staff. We had a good many of nurses who were very worried about running rates as high as even 100 post-op. And so kind of talking with them and maybe compromising so that the patient would at least meet 80% of their needs and say, okay, we're going to try this and see how well they tolerate it. Kind of give them some background as to the type of formula and why the patient would do better with it compared to maybe a standard intact protein. And again, kind of work with your nursing staff. I always tell them that it's up to them as far as they're at bedside 12 hours a day. So if they feel like clinically there is something wrong with the patient, you can always hold the feeds, check the residual amount, and ask us to come investigate. And so it is a continued follow-up. We still continue to do education 6 years later. We did find, though, at one point we were noticing compliance was low and did a survey. We had a bunch of new nursing staff that hadn't been really up to date on PEP-UP, so we had to do re-education again. It just kind of goes to show that ever-changing environment in the ICU and working to ensure that your protocols are being effective.
Great, thank you, Jessica. That was brilliant, and I think she did a wonderful job articulating how she and our medical director, Dr. Chris Watson, really helped implement this program and the rationale behind it. And so, of course, then the question becomes, does any of this actually work? To help answer that question, we did a couple things. We looked at a small feasibility pilot to basically make sure that we were doing right by our patients and making good progress. And then pending that, we did a larger retrospective review looking at all of our STICU patients. The retrospective smaller pilot was presented by Jessica about 2 years ago, and she looked at 50 TBI patients. As you can tell from the graphs here, all of these underwent volume-based feeding. They all had immunonutrition prescribed, and over half of them were at their goal nutrition by day 3, and everybody was there by day 7. So this is obviously much better than when it was certainly compared to our historical data from 2011. And we felt that we were on the right path and maybe onto something special. So with that, we continued the program, improved our education, and really tried to expand it as best we could to every single patient that came into the STICU. And so we did that. So we looked at all of our STICU patients on a much larger scale. We looked at a pre-PEP-UP historical cohort from 2011 to 2012. We instituted the program, gave education, and allowed about a year for that to take place before we looked at our post-PEP-UP cohort from 2014 to 2016. In all, it was about 492 patients. All of them were ordered a volume-based feeding protocol with immunonutrition, with arginine, omega-3, and nucleotides. This is the table from our publication. There's a lot of numbers on here, but let me just walk you through a couple of the significant findings that I think are relevant to all of us. For one, these were obviously very sick patients. We wanted to make sure that we weren't treating patients that were drastically different between the two groups. And what we found is that actually the post-PEP-UP group was actually slightly more sick, with a slightly higher injury severity score. Like all trauma centers, we calculate the ISS on all of our patients, so this was very easy to accurately track between the two groups. We looked at blood glucose levels between the two groups. We'll talk more about this later, but obviously hyperglycemia is something that we want to avoid in all of our patients. And what we found was that we were doing a much better job with hyperglycemic control in our post-PEP-UP cohort. There was a pretty dramatic and statistically significant drop in our episodes of hyperglycemia. There was equally excited for us. We were able to meet and exceed both our caloric delivery as well as our protein delivery as well. So again, statistically significant increases in both of those categories. Another way to say that is that the protein deficit of our patients, which was calculated as well, had a statistically significant decrease between the pre-PEP-UP and the post-PEP-UP cohorts. Some other ways to look at this data to help better tease out how it works and how it affects our patients. The next couple of slides really help sort of demonstrate this, I think. This is an effect plot of our PEP-UP patients looking at protein delivery. Just to help you explain what this graph is, on the y-axis, there's the percentage of the protein received over protein prescribed, and on the x-axis is the days going on from their ICU stay. Each circle that you see is a data point. It's actually an individual patient, and that individual's patient's protein received over prescribed on that particular day. You'll see the post-PEP-UPs in blue and pre-PEP-UP is in red. Obviously, there are more data points on the left-hand side of the graph because most of our patients were still in the ICU the first few days. And as we went out to about a month out, obviously most of our patients were no longer in the ICU. So most of the concentrations in the first week or two of their ICUs or of their hospital stay. And what you can see is that the post-PEP-UP group, represented by blue, is really scooting right along that 80% protein received, protein prescribed goal, right about where they're supposed to be. They got there quickly, and I think it's really worth noting that it's a very level plane. There's no peaks, there's no valleys. They're right where they're supposed to be in a homeostatic prescription. The pre-PEP-UP group never got there. They never reached the 80%. They started to trend the right way at the very end after about a month. But you can see for their entire ICU stay, the pre-PEP-UP group fell behind on protein delivery. Here's another way that simple-minded surgeons like myself like to hear data, especially on rounds when we're debating what to do. These are the odds ratios of meeting protein goals. So using the pre-PEP-UP group as a reference and looking at the post-PEP-UP group and the odds of meeting 80% protein goal, it's almost 12 times. So you're almost 12 times more likely to reach your protein goal during the post-PEP-UP time. If we look at overall caloric delivery, what we see is that basically the data mirror those of the caloric delivery. We can see here the same thing. This is an effect plots. Again, calories received or prescribed are on the y-axis and days are on the x. What we do notice here over the course of a month is that ultimately the pre-PEP-UP group does catch up to the post-PEP-UP group, but it's not till a month out. So I would argue that that's really not significant in the care of these patients. And again, what we find looking at the post-PEP-UP group is that there's really a steady state. It's really sitting right at 80% for their entire ICU stay, which is a fantastic thing. And again, looking at the odds ratio of meeting your caloric goals, reaching 80% of that, again, this mirrors the same, but using the pre-PEP-UP group as a reference and looking at the post-PEP-UP group, the odds of getting where we need to be almost 5 times more. So the odds are very much in our favor of reaching the goals that we set for our patients. This is really a separate and forthcoming topic in paper, but it's something that's really important and one that we need to clarify too. It's important to realize that, that pre-PEP-UP at our institution, everybody was subjected to a very old-fashioned gastric residual volume check policy. It was inconsistent. It was very conservative in that gastric feeds were held for very small volumes. And again, it was very inconsistent, as Jessica stated. The post-PEP-UP era actually began and preceded our newer GRV policy. So the flow sheet that was shown to you earlier came in about halfway through our PEP-UP period trial study time. So really our post-PEP-UP group has 2 subsets, a post-PEP-UP with GRV checks and a post-PEP-UP without GRV checks. It was really important that we tease these data out to make sure that there was no discrepancy here. And what we found is that there was actually 0 statistical difference between the post-PEP-UP GRV checks and the post-PEP-UP no GRV checks with regards to both caloric delivery as well as protein delivery. In other words, it was PEP-UP and not at all our gastric residual volume policy that was responsible for our protein and caloric delivery. No data is really worth very much at all if it's not safe for our patients. And as Jessica mentioned, there was a lot of concern over the safety of instituting such a policy in such a unique patient population. But as you can see, and as we'll talk about, our practices are indeed very, very safe. Looking at this, we found absolutely 0 statistical difference with regards to refeeding syndromes, diarrhea, or emesis. And we actually found a significant decrease in macroaspiration in our post-PEP-UP group. Macroaspiration was defined as either a witnessed aspiration event or that was confirmed bronchoscopically. So in other words, PEP-UP in our institution was at least as safe, if not slightly more safe, than what we had done prior. Glycemic control is particularly important in any ICU, and as such, it deserves some additional time to talk about. Here we are looking at days recorded of events of both hyper and hypoglycemia. And what we can see is that if we look at days of hyperglycemia, there was a statistically significant decrease in our post-PEP-UP group. And days of hypoglycemia, there was also a decrease as well. Not significant, but trending in the right direction. Another way to look at this data, instead of days of hyperglycemia or hypoglycemia, are actual individual occurrences of hyper and hypoglycemia. And here we're finding the exact same thing. We find a statistically significant decrease in hyperglycemia and trends in the correct direction of improved episodes of hypoglycemia. And yet there's even more to this story, because the post-PEP-UP group that was analyzed, actually more of those patients carried with them a diagnosis of diabetes. So it would have been very natural to assume that we should have had a harder time controlling these individuals' blood glucose. It should have been worse, but actually we were able to do it better. And let's reiterate again why this is so important, or as to say why we even care about hyperglycemia in the ICU at all. It's fairly well established, although there's some controversy over specific ranges, But specifically in the ICU, it's been shown that hyperglycemia is bad. It carries with it a higher risk of mortality, is an independent risk factor for infections, and can be predictors as well for hospital and ICU length of stay. More importantly, though, I think it's useful to utilize hyperglycemia as a surrogate really for patients' health, specifically as it involves infection. I think all of us have been on ICU rounds, and patients appear to be going well, except for all of a sudden their blood glucoses are trending in the wrong direction. They're trending up. Something is wrong. Something is happening with that patient. Something is about to go really bad with that patient. And so it's not so much that we improve patients' outcomes by treating their hyperglycemia, right? If we put someone on an insulin drip, their hyperglycemia is going to improve. But I think the more important thing is to put them in a homeostatic place where their blood glucose doesn't have to improve. If we're taking better care of our patients, we won't get that uncoupling between their glycemic control and their overall health. And I think this is a really important surrogate for all things in the ICU and a very powerful and positive aspect of our study. When we look at secondary outcomes for our paper, there really wasn't much here. It's largely benign. We didn't see any changes in mechanical ventilation, changes in ICU length of stay, changes in hospital length of stay. But I think it's important to note that it's really hard to show changes with any of those things, simply changing one aspect of their care. This is a struggle in all ICU studies for that matter, insofar that changing one variable is really hard to affect larger things. There are so many factors at play that go into these patients in terms of their ventilation and their length of stay that I really wouldn't expect much of a change on these things. We did note that there was a decrease in pneumonia, and that is in the chart and it's in the paper. And that's true, and that's a very good thing, and we're all very happy about that. But I would caution a direct link between the decrease in pneumonia and the implementation of our PEPUP protocol. There are a lot of efforts at this hospital, and I'm sure at yours as well, aimed at decreasing pneumonias, at ventilator-dependent pneumonias, at all aspects of pulmonary care. And a lot of efforts have been going on at our institution to try to specifically target those. So again, it's a good thing, and we're very happy, but I caution a really strong and direct link between those two. As an added bonus, we did see a pretty significant drop in our TPN usage between the two groups as well. And this is, on the one hand, not unexpected. I think an aggressive early enteral nutrition program should come with it a reduction in TPN use, but it's nice to really see this in the data as well. We had initially excluded the TPN patients from our initial analysis during the paper. It was obviously a confounding variable with regards to their protein and their caloric needs and their delivery. And so we had taken those patients out. But then once we took them out, we decided to actually analyze them and see what was going on. And you can see in the pre-PEPUP group, which, by the way, was a smaller cohort, right? So it's a smaller cohort, and it's actually got more patients who were on TPN, and those patients spent more time on TPN. So our post-PEPUP era, we are very much reducing the amount of TPN. There certainly is going to be variability in prescriber habits as well as trends in the nation, but nonetheless, there's been no specific program targeted at reduction of TPN. So I think these data are valid, and I think it really is another added benefit of the work we're doing and the overall efficacy of delivering both protein and calories using a volume-based feeding program in a surgical trauma ICU. So that brings us to our second polling question. We've been talking to you, obviously, about volume-based feeding in a surgical trauma ICU. We've talked to a lot of folks around the area and around the country and trying to see how many folks are actually doing this. So we just want to get a sense of actually how many of you out there are using this type of protocol. It doesn't have to be PEPUP specifically, but some sort of volume-based protocol in your surgery trauma ICUs. So we'll give you a little bit to answer.
Okay, it looks like we've got about 15% responding as yes, and clearly the majority, the answer or response is an 85% no.
And that's certainly consistent with what we're hearing when we talk to our colleagues. I suppose it's a good thing, otherwise we would have just been wasting your time if you were all already doing this and maybe better than we were. So it's certainly, I think, a newer trend that's out there and hopefully something that can grow from here. I'm going to turn it back over to Jessica, who's going to talk about some conclusions and where to go from here.
So thank you, Dr. Press. We were able to find with our study that PEPUP was safe. It was more effective in the delivery of our nutrients, specifically at delivering protein, which we know how important that is in our surgery trauma population. We improved glycemic control and decreased use of TPN with an aggressive feeding program. So we also have to ask if this is, STICU Summary. So we found that we have to feed early. We have to use a well-tolerated and evidence-based semi-elemental immunonutrition formula, and we really need to form a change team to implement your volume-based feeding. I can't speak highly enough of our ICU, our nursing staff that jumped on board when we kind of brought our benchmark results to them, our nursing educators, nursing managers, and then also our physicians, and having the dietitian on rounds. All of that really helped contribute to the success of the program and contributed to the great success of our study. And so you have to ask the question why this isn't everywhere. I think we have to look at the data. There's not much in surgery trauma patients. Like we said at the beginning, most of our data is in medical patients. So it causes a little bit of hesitancy to start it in a population that has more challenges with feeding and a higher incidence of GI intolerance. And when we did publish our data, we were really excited to bring it back to our staff to show that, hey, this is safe in surgery. It also takes the right people, like we mentioned before, strong leadership with your physicians, your dietitians, and nursing. Before, we had nurses that knew they were supposed to feed, but the culture really wasn't there to promote it because of past evidence and, again, those concerns over those challenges. But now I have nurses that walk up on rounds and say, okay, the patient's been here, they're resuscitated, can we start PEP up now? Or they'll come up and say, hey, they just got from surgery, I'm going to PEP them up, can you help me calculate the rates? And we've really established a culture within our ICU to put nutrition at the forefront of everyone's mind to make sure that we're starting early, but also meeting those goals that we need. All right, well, we really appreciate you guys tuning in today. We're going to turn it over to Yvette for questions.
Thank you so much, Dr. Prest and Jessica. It's a very, very excellent presentation, and really appreciate you sharing your data with us. And I certainly am excited to open it up to questions. I do want to make one comment. I really think an important point was made, Dr. Prest, when you were talking about, avoiding hyperglycemia in our ICU patients. And it is a different mindset, I will say, when you think about treating your patients and a different way besides just giving insulin when you see hyperglycemia present. And with your data, truly what it makes me think about as a clinician is there is this data already to support the role that nutrition plays with our ICU patients and to be proactive rather than wait to see the hyperglycemia come into play and just consider the role of insulin. So thank you for that. A lot of great information. And so we're waiting for questions to come in. So the first question that I have, how long do you use the immunonutrition formula with your protocol?
It's a really good question, one we get quite often. We typically will use it up to 2 weeks, depending again on their length of stay in the ICU. As they transition out of the ICU into our step down and floor units, we began to transition them back to the standard formula. It is patient specific based on how well their wounds are healing and upcoming surgeries, and also tolerance as well. Most of our patients, though, as they transition out of the ICU to step down and floor, will go back to that standard formula, and that can be anywhere from 5 to 7 days, depending on how sick they are in the STICU, but usually it's a max of 14 days.
Okay, great. Thank you. Another question that we have in regards to the hypodynamically or unstable patients that are on pressors, how do you address those types of patients in your ICU with the PEP-UP protocol?
Great question. Jessica and I are laughing because, lots of reasons. I think depending on how individuals are trained, it is very much affects this. I was trained by a bunch of brilliant people, but they were very old-fashioned, and we were very, very reticent to treat anybody who was on any vasopressors whatsoever. There is a decent amount of data that shows that feeding on some vasopressors is safe, and Jessica is certainly in the camp and has done an excellent job trying to change my mind over the last few years, and she's very successful at that. But in terms of an actual number, a specific dose of Levophed, for example, that is really not very clear. We're in the midst of actually doing that study right now, looking. But as a typical rule, we typically are okay feeding on Levophed of about 12, but we do very aggressively trend their lactic acid. And so as long as that value is less than 2, we feel comfortable feeding. I should note, though, and I think it's an important teaching point and one that I make on rounds a lot. Things like a lactic acid or your levofed requirements, those are all reactive values. So, if your gut's going to have intolerance and is going to die, it's going to die, and then your lactic acid is going to go up. It's not going to be the other way around. So you have to have a really high clinical suspicion about what's going on with the patient population. Typically, like I said, if those numbers are in a safe range and we feel comfortable about it, then we're okay feeding.
And to point out too, with our gastric residual policy, when we went to a no check policy, we had to really do a lot of education to say that we don't just check all together. If there is a sign of distension or the patient is complaining of nausea, which can typically come before the pressors or the lactate, you do need to check. And that's why we have the higher threshold, but we also trend that threshold to see if there is something wrong.
Okay. Oh, that's good to know. Thank you for sharing that. We do have another question, also in regards to how you address the PEP-UP protocol in your patients that are at risk for refeeding syndrome.
That's a really good question. One safety outcome reason we measured it is because you can see refeeding syndrome high in trauma populations and in surgery patients that come in malnourished. We are aggressive at checking our electrolytes, and we also make sure we're replacing, but we have protocols with our nursing staff that if our electrolytes are low, we've just started feeds, we do not increase to that goal total volume until they've been replaced and those levels are have increased to a certain level. So for specifically with phosphorus, if our level is less than 2, we ask that they do not increase to goal yet. We replace and recheck, and when it is greater than 2, we'll increase to the goal total volume.
It's a really important topic because it gets to the relationship between the physician, the dietitian, and the nurse. Everyone's got to be on the same page. And I joked earlier about the folks that trained me and about how conservative we were about feeding on vasopressors. There was a really good reason for how they got to that state, and that was because we were a very large institution that had about 50 ICU patients scattered over 4 different units that we were trying to run. And it was impossible to really have the relationship that Jessica just articulated. We're at sort of a sweet spot at this institution where we have an 18-bed ICU, a dedicated dietitian who's with us on rounds, and a nursing staff that, even though we have nursing turnover like everybody in America does, it's a small enough place where we have a very good relationship with everybody there. And the policies that she just articulated about adjusting tube feed rates, about not doing certain things until protocols are followed, about holding until lab values are back, those are things that are really honestly only possible in certain size institutions, and ones that have a very good relationship amongst all the important stakeholders, and ones that have really good and effective leadership and team dynamics. So I think we're able to do that because of the things she was able to articulate. But more importantly, I mean, anybody could come up with those policies, but trying to actually get them enacted is really the hard part. And that's where the team dynamics and the leadership between physicians, nurses, and dietitians all comes into play.
Excellent, excellent. I know previously you had made a comment about the importance to go back and make sure that protocols are in place and they're being implemented. You certainly spend a lot of time, and I'm sure a lot of education with the medical staff to initiate, say, a new protocol. And of course, it's really important that you're evaluating and making sure that these protocols are still being followed or implemented in a more ongoing case. Can you share a little bit, how are you making sure that the PEP-UP protocol in your institution is, continues to be implemented? And have you had situations where maybe changes have come about throughout the process, or now that it's been implemented for a while? Can you share a little bit about that with us?
Absolutely.
Yes. Like I mentioned earlier, it is an ongoing education process. One thing that we did is we have a daily rounding sheet with our team, and it goes through everything as to if they have a central line, do they have a Foley, are they on antibiotics, what are their vent settings, and on there, there's a specific what rate are they at right now? Do they need to be pepped up prior to being made MPO for surgery, or do they need to be pepped up post-surgery? And so that occurs as a conversation on rounds. And then the dietitian walks through in the afternoons just to check and see, hey, has anyone had the ortho diet status change? Do we need to pep them up? We have bedside pamphlets and charts that we have displayed for nursing staff. And we've kind of also talked with them, you mentioned, have we had any instances where we've had to change the protocol? Some of the nurses said, hey, listen, I just don't have time to calculate this out at bedside when I have all of this going on. Is there kind of a shortcut? So we've done some education about if you just even increase them by 20 or 30 mLs to catch them up for the time anticipated to be missing or the time that they have missed while in the procedure, you're still going to be able to meet close to that 80%. So that's kind of helped overcome the challenges. We've had nurses that were non-compliant and their response was, I just didn't have time to calculate that out. And so we've kind of worked around that. We send out that survey to see if we see low compliance rates. We send that survey out and ask specific questions of, do you know how to PEP up? Do you know what to do when this happens? And we look at those responses to maybe see if there's a target area we need to go back and work with our educators on. But really kind of bringing up on rounds, we have our residents involved, our attending physicians. Sometimes even our pharmacists will ask, hey, are we going to PEP up this patient? But to kind of help with that culture on the ICU.
We also have a monthly STICU meeting where we talk about all sorts of things. And nutrition is a big part of that. And we actually audit certain patients and see what's going on and see if we need to actually launch a more formalized education or, kind of go from there. So it's on everybody's mind. It's on everybody's brain. I remember that when I was in training, learning how to do central lines, I was told that I needed to spend at least twice as much time preparing for the procedure as actually doing the procedure itself. And I think implementing a protocol like this, the logic is exactly the same. Planning and having a stepwise approach for how to continually educate is much more important than actually rolling out the program itself.
Mm-hmm. I think that's an excellent point. And, based on our poll today, where we have the majority that are not currently following a volume-based feeding protocol, is there one or two action items that both of you would recommend? So, for example, someone that's listening to today's presentation and it's a lot of information, just maybe one or two tips or points of what would be a good next action item when you think back to when you were first getting started and thinking about, wow, how would we do this? How would we go about starting or initiating this process? What tip could you share with our audience today?
Oh, that's a really good question. I will start with saying that the very first day I walked into the surgery trauma ICU as the new dietitian, I was handed the packet and said, hey, today we're starting PEP up. So I was kind of thrown into it. But one thing I would maybe focus on to start with is, it looks like majority of our audience is starting sooner. It's also take a look at how quickly you're getting to those goal total volumes or meeting 80%. So instead of increasing maybe by 10 by 6 hours, if you have a formula that's easier from a tolerance standpoint, increasing them a little bit faster to get into that goal volume, and then restarting them as quickly as you can post-op at a little bit of a higher rate than their goal rate, just again to kind of see how well they're tolerated. And then the second thing would be to try and change your gastric residual volume policy so that you don't have as many interruptions and provide nursing staff with kind of that flow diagram of how to. So if there is an interruption, and you're not waiting until the next day.
And I would just also add on sort of a cosmic point, you really need leadership to buy into this. This doesn't work as a grassroots effort very well. This worked here because the director of the ICU wanted to do it, and he was able to lead, convince the dietitian, the nurse manager, and the nurse educator. And those four people were all very much on board. And as such, we're able to bring everybody else on board, right? You've got to have nursing leadership because there's got to be nursing education that has to actually affect and lead the actual nursing staff. You have to have physician leadership involved with resident, with fellow education, with fellow attendings, and sort of coordinating everything else. And you need a dedicated dietitian. You can't have somebody who's rounding on 6 different ICUs that day and seeing outpatients, also trying to help the nurses calculate rates and be on top of what, if we're enforcing our gastric residual volume policy. You really need dedicated leadership, because if that isn't there, the whole thing falls apart. No one's going to care about PEP up if the director of the ICU doesn't care about it. No one's going to care about, no nurse is actually going to be engaged if the nursing educator and nursing manager don't care about it. So you have to have the leadership buy in, lead, and commit to this type of program.
Wow. Well, I think we will end on those fantastic recommendations and tips for our audience today. Thank you again, Dr. Prest and Jessica, Justice Reef. An incredible presentation. Really appreciate you taking the time to share your experience and your knowledge with our audience. And also thank you to our audience today for your participation. On behalf of the Nestle Nutrition Institute, we hope that you found this information useful to your practice and enjoy the rest of your day. Thanks so much.